We got 3 orthopedic sessions here today. Nothing tricky about it, very straightforward stuff. It's not all fractures. They like you to know about a few fracture negative things like compartment syndrome and some important ligamentous injuries. So those are in there, some vascular stuff they might want to get to through these orthopedic things. As I mentioned, they're in the trauma section of the exam, a lot of it. And so let's just jump right into it. Day in and day out emergency medicine. So again, it shouldn't be the kind of thing that, if you were to ask me about rheumatology, like I'd need to read up on that stuff if I was facing an exam, because I don't do all that much of it every single day. Got to review the things and the labs and this. But orthopedics is kind of day in, day out stuff. It should be there. What are the complications of a fracture that we're trying to avoid by doing good emergency management? Compartment syndrome. If they have poop in any question, pain out of proportion. Pain out of proportion. I don't care whether it's belly pain, that's mesenteric ischemia. Whether it's a fracture with poop, that's a compartment syndrome. There's no place in emergency medicine where poop is good. So if the person in the question is asking for a second round of pain meds, what are they trying to communicate with you? Pain out of proportion. Fat emboli, more of a little bit of a delayed thing. Long bones, marrow-filled bones. Non-union, malunion. There are certain fractures which are very high risk for non-union and malunion. And you want to know about those. And they, obviously orthopedic consultation is warranted for those to avoid the bad outcomes. Post-traumatic arthritis, avascular necrosis, things like the scaphoid fracture where it's sort of retrograde vascular supply, higher risk for AVN. And then any open fracture needs to be worried about whether it could be osteomyelitis that they might develop, and they need to be considered, to what degree does it need to be washed out, etc. And so those are the complications that you're looking for. And, when you have an extremity injury, the chart is really pretty straightforward in terms of the architecture, yet I could pull charts at Stony Brook or at LA County, and they would be missing things. Someone comes in with an upper extremity injury, the history should start the same way. 36-year-old right-hand dominant carpenter. I need their hand dominance of their occupation because it educates me as to what's relevant about what I'm trying to achieve. And in the physical exam, I need the joint above, the joint below, because there are a lot of joint above and joint below injury patterns we're going to talk about. You don't always have to have x-rayed the joint above or the joint below. It would be fine if someone had some medial malleolar tenderness to say that the knee was full range of motion, non-tender, including the fibular head. That means you don't need to x-ray the knee. But you have to at least examine the joint above, joint below, sensory motor vascular, skin and compartments. And I'm not saying you measure compartment pressures, but just a little squeeze just to see how much tenderness they are. And it's amazing how often the skin exam isn't there. Skin exam is really important. Is it open or closed? That's a pretty big differentiation. Anyone you're going to put plaster on or a splint on needs a skin exam. Was the skin normal when you put that splint on? What am I doing?
You adjust it
back to the middle this way? Yeah. All right, is that better? So, so anyone you're going to put a splint on really needs a skin exam. Cast wadding and the padding for splints is a well-known cause of staph infection, but was it there first or not? And so those need to be there. All right, growing bones are different from adult bones because they have a physis and they got to get their length to them. And here's the standard stuff that you see, the epiphysis, then the physis, which is the weakest. In fact, ligamentous insertions are stronger than that physis growth plate area, so fractures happen around that often. And then you got the metaphysis, which is the bone getting fatter, and the diaphysis, which is the shaft. Salter, slip above, lower through ram is how you spell Salter. Slip above, lower through ram. And that gives you the Salter classifications. Now, you say above, lower, what does that mean? You have to picture this picture. As long as you can keep that picture in your head, slip above, lower through ram tells you Salter 1, uncommon, the slip. You might need comparison views for Salter 1s. Salter 2, the most common by far. Salter 3 has an intra-articular component because it's lower. Salter 4 goes all the way through. And Salter 5 is the crushed physis where you can have full growth arrest. And so the Salter classification is about knowing what the potential for growth disturbances is and knowing that in both Salter 1 and Salter 5, the x-rays can be close to normal. you might need comparison views. The American Academy of Pediatrics says you shouldn't routinely get comparison views on any extremity. You should get the affected side, and if you think a comparison view will help you, then get it, but don't routinely order them, with one exception. You're getting an AP of one hip, get an AP pelvis, shoppers. It's a blue light special. Get the AP of both hips with the first shot. All right. They always talk about Salter fractures being with long bones and growth disturbances, and indeed that's true. And that's why a Salter-Harris 4 of the upper extremity is much less important than a Salter-Harris 4 of the lower extremity. Because I don't know if you noticed this, most of us for the large duration of our lives walk on our hind legs. So a shortened upper extremity just means you need to lean over further to get something. But a shortened lower extremity is a disaster. That means you limp and you have low back pain and become addicted to oxycodone and you torture every emergency room for multiple zip codes. So a shortened lower extremity is a very bad outcome. Let's look at these. So here we have the yellow arrow showing that it slipped off, and the blue arrow showing, truthfully, I don't know what the fuck it's showing. It looks pretty normal to me. Thank you for putting me a blue arrow there. But it slipped, and the yellow arrow shows it. And you might, this is where your ability to examine someone accurately and interpret your films. Remember that X-ray plus exam is greater than X-ray, no matter how much you know about X-ray. Radiologists don't like that simple fact, but when you know where they hurt, your ability to look at the X-ray is way greater than some radiologist who hasn't got any of the benefits of exam. Here we have a non-Salter-Harris fracture of the ulna, no growth plate involved, and a above Salter-Harris 2 of the distal radius. And here we have a Salter-Harris 3 fracture of the lower extremity going intra-articular over the talar dome. This is a Tilleux fracture, a Tilleaux fracture. Suddenly, the lower extremity is all French, the upper extremity is all Italian. I don't know how they divided it up. Happened somewhere in the medieval ages. In terms of eponymous fractures, like they would never say on the question a Tilleux fracture without telling you what it is, without telling you an intra-articular distal to the physis fracture. So some people worry, do I have to learn these eponyms? No, you don't. Only the most basic eponymous fractures are named on exam questions, like a Colles. They would never call out a Tilleux fracture. But a Tilleux fracture is an adolescent fracture that's pretty important because the intra-articular piece is big, so that's actually a pretty bad Salter-Harris 3. But even noting that, with the 3 arrows there showing the large extent of growth plate involved, they usually don't have growth disturbances with this fracture. The big problem is incongruity in the joint line where those two pieces, where that piece comes down in the middle, they get some irregularity there with post-traumatic arthritis. And there's a Salter-Harris 4 that's probably, although we generally think, the higher the number, the worse it is, that's probably not as bad as this Salter-Harris 3. This is probably a worse fracture than this one because this one's off the main weight-bearing axis of the talar dome and really minimally displaced. So I think we've already talked about this. Most common age is 10 to 16. Again, long bones, they say, but don't forget that Salter-Harris fractures happen in fingers too. And if you look at sort of med-mal fractures that we miss as ER docs, where we read the films and someone may read them later, but fractures that we miss, pediatric hand fractures and finger fractures are pretty high on that list. Pretty high on that list. So look pretty careful at your pediatric hands because they can hide little Salter-Harris fractures and crumples of them. And here's your incidence. You can see type 1 is pretty rare, type 5 is very rare, and the type 2 is really the dominant deal. Let's talk about the hand. Hand's pretty important. Here's your distribution area, sensory motor vascular. We're going to talk about sensory motor and vascular. This is the sensory. And it really depends on where the injury is in terms of how detailed that exam needs to be. Someone's got they got a stab wound or an injury to their biceps. And I just need to know, did the radial ulnar median nerve get past that injury? So I could just go here, touch that, bump, touch that, bump, touch that, bump, bumpity-bump. That was how I told. When you don't need detail, bumpity-bump is enough detail for the sensory exam. But if they had if they had a hand injury, a machete to the palm or something like that, I need to do every digital nerve, ulnar and radial aspect. And so the detail that's needed on the chart for these sensory and motor things depends on the nature of the injury. But it's pretty standard sensory distribution. Then they start asking the motor stuff, and the motor stuff gets a little trickier. And I used to struggle with it until one of my faculty told me, if you just remember the median nerve is British, you're in business. And I was like, what do you mean it's British? He goes, it drinks tea. Pincer grasp, note these fingers are not median nerve. Pincer grasp, flexors at the wrist, flexors at the elbow, and pronators. And once you have the median nerve straight, then the ulnar nerve is all the intrinsics, and the radial nerve is the extensors, and it becomes pretty straightforward. So if you remember the median nerve is British, you're in business. And then there's one other thing to know, that there's these pure motor and pure sensory nerves to the upper extremity. So the pure motor nerve that you need to know is the recurrent median nerve. We'll get to that. That's pretty important. And the pure sensory one you need to know is the dorsal branch of the radial nerve. So the dorsal branch, here's your radial nerve coming down the radial side, and it's going to go down to do all the extensors in the hand, but there's a branch off right here that comes off that does the back of the hand, and that branch is a pure sensory branch. That's why you'll see people that get hit with a billy club or have a window sash drop on the back of their arm, and they come in, they got this numbness in the back of their hand, but all their motor's intact. You're like, how can they have the sensory of the radial nerve out, but the motor's in? No, that's because there's a pure sensory branch that comes off the radial nerve about mid-forearm. And then the $1 million nerve comes off right at the distal flexor crease and does this lump, does the thenar eminence, aka, and this is worth remembering, these are the kinds of functions and come up on questions, goes to the thenar eminence, the $1 million nerve does the oath muscles. Opposition, abduction, flexion of the thumb, but no sensory. It's a pure motor nerve. Why is it called the $1 million nerve? Because if you were a hand surgeon and you were making and hand surgery sounds really fun until a lot of these specialties sound really fun until you actually learn what their life is like. Take, for example, have you ever wondered why neurosurgeons are such pricks? 7+ years of residency. They open an office. 1/3 of the patients they see have low back pain. Holy shit. Imagine how mad you'd be if that was your life. You thought you were going to be a neurosurgeon, getting brain things and doing stuff. 1/3 of every day of your life is low back pain trolls, desperate for surgery. Oh, God, I'd be mad. These hand surgeons sound like they got a nice life doing these interesting things, these interesting cases. Like 1/3 of their shit is carpal tunnel and chronic stuff. And so when you go to unzip a carpal tunnel to relieve it, there's a little nerve that you don't want to hit right there at the flexor crease. The black and white picture shows it best. It's just that little nerve going down to the thenar eminence. And if you happen to zip that while you're trying to unlock their carpal tunnel, that'll cost you about $1 million because it's a pure motor nerve that's really small and hard to fix. And that's why it's called the $1 million nerve. Because if you hit it doing a carpal tunnel surgery, it's going to be expensive. Amputation care, I've worked most of my career at the university hospital that's receiving the amputation. Many of you worked at the places that are sending them. Please don't tell them we're going to put them back together again. Tell them the experts are going to look at it because nothing replants better than false hope. Then we have to debride them of false hope later on. Just don't tell them we're going to do it. But here's what you should do. Go in a plastic bag, not directly in the water. You don't want any osmotic injury. You should know what the appropriate digits that might be replanted are. Then set those up and get them over as quickly as possible to the place where they do replantation. I remember there were these two guys in LA County we have a railroad yard down by LA County where they unload stuff and the railroad cars come in, and there are a lot of homeless people down there. There's encampments. And two of these homeless guys were sort of drunk, and they were doing this double dare. I can stand closer to the moving train than you. This doesn't sound smart to me. So the train's going by, and they're standing closer and closer, like mumbly peg, there's these dare games. Except there's that little suction in the gap between the trains as it goes by. There's a little negative pressure. And you can see if you were a little tips, leaned over, cleanly took his shoulder off. Just the sharp corner of the railroad. So they brought him in, and it's right around the corner from the hospital. So he got to us like in 3 minutes. So he's hemorrhaging like stink. We're transfusing. We're trying to get the bleeding stopped. We're doing all the stuff. We call the replant team. We're working like mad. He needs a chest tube, all this stuff. He's getting intubated, rapid sequence, blah, 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 blah. And the transplant team comes down. They start looking at the arm. They're like, here's this. They start pulling stuff out. Yeah, there's the vascular stuff. They're like, yeah, we got a lot of work to do. We're going to the OR. They left the guy with us. They just took the extremity. And the nurse is like, whoa, whoa, whoa there. That's got to be identified if you're going to the OR. I mean, we got to name that. You can't take an unnamed body part to the OR. They look at her like all confused. No, that shit needs a medical record. They gave him a hard. They're like, well, give it a medical record. We'll merge them later. It was one of those bizarre moments. I was like, yeah, go ahead, guys. You're not worried about anything we're doing down here, huh? He actually had a pretty good outcome. So here's, a nice, clean, long incision of an important finger and index, part of the grasping function. That's probably one of those metal cutting presses that did that. That's an excellent replant. So you'd want to put it in that dry bag with the gauze, and then that goes in ice water. All right, some specific injuries. We're not going to go through all of them. The boutonniere deformity. But I like having the boutonniere deformity because it reminds you of what stuff that you might know from everyday emergency medicine, but you could still fuck up the question. Let me show you what I mean. Everyone in here knows what the boutonniere deformity looks like. There it is, right? The PIP is flexed, the DIP is extended. You kind of got that. But if I asked you to identify the exact injury and then I put a bunch of choices out there, you'd be shocked at how many would struggle finding the central slip extensor hood disruption near the PIP. So even though you know what the injury looks like, you have to, on an exam, know the words that go with it. And so you can see that gets a little tricky. And it's the lateral bands that pull it into flexion. So here's the picture of the boot. There's the central slip just past the DIP. There's the lateral bands pulling the PIP into flexion, and the DIP into extension. And so this sort of illustrates one of the things about doing exams is some things that are really familiar to you, you could still get wrong because the words are not familiar. The image is super familiar, but the words may not be that familiar. They want to call this a felon, and felons are mostly staff. I don't really like this image as a felon. How many of you think that whole finger's swollen and red? I do. Next thing is, most felons don't have like an eschar. What's that black dead shit on the end of that? Right, usually it's just a pulp fingertip infection where all the compartments are involved. The treatment is I&D plus antibiotics. It's hard to I&D all the compartments. So if you were to do that fat arrow in this image, you would theoretically, if you talk about these septations, and there are people that argue whether these septa are real, but there's these sort of components of the pad of the finger. If I was to make an incision like is shown there, I would have successfully drained one of the septated compartments. I want to drain them all. And so you can fish mouth this. I don't like fish mouthing it. Some of you are probably fish mouth fans. I just feel that sort of leaves the finger all blown up and open. I like to preserve the tip of the finger and go through with an 11 blade. That's my favorite way to do it, and pull some iodoform gauze through. But there are a bunch of recipes. Jim Roberts, who wrote the procedure book, gives a bunch of viable different ways to go about it, but that's my favorite. But the key with the felon is because there's these different compartments and because this thing is tough to drain thoroughly, they get I&D plus antibiotics as opposed to the paronychia, which is a single compartment, little bulb of infection on the corner of your nail, which just gets I&D'd, no antibiotics. Now, they're saying that's a felon. I could be from the GU lecture. I got no idea what that is. And then there's all this nail bed stuff. Remember, the nail comes with the germinal matrix at the base, and there's the mid portion of the nail where the nail plate and the nail bed are really important. And then there's the distal third where it's not that important. You got a herpetic Whitlow image down the bottom of that. Please don't I&D that because they'll get herpetic myositis or herpetic tenosynovitis, and it'll hurt for a long time. Who gets this? Moms, barbacks, barbacks, dental assistants, people whose fingers are in other people's mouths where their herpes is will get this treatment. for the Whitlow is just leave it alone. The treatment for a paronychia is to I&D it. Now, I love this picture. There's so much to talk about. First off, all right, that's a paronychia. Sure, okay. It sort of looks like it's nastier than average, like it might even be tracking under the nail a little bit, right? Then I got the whole finger red, right? The whole finger's red, like even a lymphangitic streak. And then I got that thing between the fingers, which is the distinctive, and Jan already talked about it when she was talking about STIs, STDs. It's about 7 millimeters across. It's a hemorrhagic base. It's completely circular. Every time you see one of these, all these criteria will be met. It looks a little frosted, like it looks, there's that gray sheen on it. They call that frosting. And the other thing that they'll say about it is, well, what color would you call it? Gunmetal gray. That's disseminated GC, right? With the tenosynovitis involving the finger. Now, I don't even want to be anywhere near it when you're I&D in that thing, because I'm pretty sure that paronychia is not your usual staph or oral flora paronychia. I'm pretty sure that paronychia is teeming with diplococci that I don't want to get to know. Would you expect to see those organisms on ground stain? No, just like with a septic joint, you probably wouldn't see them, but they're there. They're there. So that's a great image for disseminated GC with the widespread tenosynovitis, and in this case, a paronychia, which is a pussed out one of those little lesions. Here's a normal paronychia. You can just slide the knife in, the 11 blade along the nail. You could, if you talk to different people, some people make a whole shop project out of this. They got to put the thing in, the stuff they'll sling under. They got to get the laser routed jig together, put together. Norm Abramson comes in from the Yankee workshop, and they have like an hour consult. You're like, come on, just stick a blade on the thing and be done with this. And that usually is true. But you don't have to, they show stuffing some stuff under there. Most of these, you don't need to do that. And they don't need a simple paronychia. It does not need antibiotics. Although that paronychia needs antibiotics, right? That needs the whole deal, the ceftriaxone, the zithro, the whole thing. All right. This is an important one. You see a dorsal hand cellulitis. This happens to people all the time. They skin their knuckles, they scrape something, they get a dorsal hand cellulitis. And it is a dorsal hand cellulitis that started as a dorsal injury to the skin. But remember that of all those swollen hands, about 1 in 100, it didn't come from the back of the hand. They actually have a puncture wound either between their fingers or on their palmar side that then the infection penetrated up through the metacarpals and blossomed on the top. And that's, it looks like sort of a mushroom on side or a collar button, and that's a collar button abscess. Any question you see about a dorsal hand cellulitis, if they're asking you what else should you do, you want to look really carefully at the palm and at the interdigital spaces, because sometimes these are volar aspect puncture wounds that come out on the dorsal side. And you also want to look for that splinter or finger or foreign body or whatever else might be on the palm. So that's a collar button abscess. Here we got the rose gardener with the fungal infection, with the skip lesions, with sporotrichosis. Pretty common question because we don't see a lot of fungal infections. Right? Fungal infections come cutaneous and superficial. That's all the tinea, capita, crura, you name it, pedis. Right? Then there's the next level of fungal infections, which is the tissue-bound infections, of which there aren't many. The carrion is when tinea capitis decides being superficial isn't good enough for me. Becomes a soft tissue infection. Sporotrichosis is a soft tissue fungal infection. Madura foot is a soft tissue fungal infection. That's when tinea pedis isn't enough. You want to go further. So there are these tissue-based ones, and then there's the deep or the multi-system ones like cocci and histo and all those other things that happen. So this is an unusual one. Treat with itraconazole. There you go. Why does a rose thorn give you fungus? Because all plants are in a constant battle, right? Plant chemistry, and the reason drugs used to come from plants is because plants have to survive in a world where they're constantly attacked by insects that might want to eat them and chew on them, funguses, molds, etc., that are the enemy of the plant. So the plant has to defend itself from that. And a rose, there's no plant that's been more crossbred than a rose. And every time we crossbreed it to get the soft tangerine color or the slight this or that, or the one, we keep specializing in roses. What happens when things get interbred too much? Do they get genetically stronger or genetically weaker? Right, so the roses has got chromosomes that are snapping like dry pretzels because we've overbred the things and they can't defend themselves anymore as a plant. So every rose on the planet is covered with fungus and aphids. That's just what it is to be a rose because we've eliminated all their natural defenses by overbreeding them. And that's why you don't even have to say which rose. A rose thorn pokes you, you're going to get sporotrichosis. All roses are covered with this fungus. All right, gamekeeper's thumb. This is a pretty, hard to miss gamekeepers. It's a big avulsion fracture by the ulnar collateral ligament, and it can happen with skiing as well. These can be negative where the hand opens up and the joint is unstable. So remember, they can be X-ray negative and have a significant ligamentous injury where you have to examine the other side to find them. These can sometimes require surgical care. The complication here's, I had one of the, we're not going to go through all my injuries because I've had a lot of these, but there's a gamekeeper's on this side. See how wide open the grasp is on one hand versus the other? They don't match up. And I got the big knob there. So I had some chronic instability from that. To this day, if my girlfriend hands me a jar of mayonnaise, I can't open it. I got to hand it back. But I can palm a basketball, so I'm really happy with the outcome. I still can't play basketball, but I get picked when we're playing pickup at the gym because I can stand there like this. When you can palm a basketball, they think you might know how to play it. It's totally misleading. So I'm very happy with the outcome because I got that grasp. But I still have laxity there, and that's the complication of it. Now, if you get on a 2-ton animal or a 1.5-ton animal with horns, and you try to hold on to it by wrapping a rope around its belly and making a knot and holding on with one hand, if you get thrown off the high side of that while you're trying to hold on to that knot, that'll break out the other ligament on your thumb, the radial collateral ligament, and that's called bull rider's thumb. My feeling is if that's all you got, if that's the only injury you have after strapping yourself to that animal, consider yourself lucky. Walk away. Walk away. Tip the rodeo clown. Get out of there. Jersey finger. Some of you thought that was the GC infection we looked at. No, it's actually another thing. Different jersey here. Jersey finger is almost always the ring finger. There's a classic example. They can put that image up. That's a jersey finger right there. What's happened is the FDP, flexor digitorum profundus, has avulsed distally. And if you were grabbing someone by a jersey, if you get your index and long finger in, what happens? Into the collar of the jersey. If I get them all in, I tackle you or the shirt tears. If I get these two in, I tackle you or the shirt tears. If the person spins and I get left with these two in, now we got a problem. That's not strong enough to bring you down, so now my FDP goes out. And that's why it's almost always the ring finger and not the other ones. Almost always a ring finger. 90% of the time. It says 85, but it's even more than that. Mallet finger or baseball finger, forced flexion of DIP, avulsion fracture may or may not be there. Here's sort of the classic image with the, and we'll just splint that in a little bit of hyperextension, right? All of you have managed these, no big deal. And here's some images of it with and without the fracture. Metacarpal fractures of the hand. By the way, when you're dealing with fingers, I see people number fingers all the time. Please stop numbering fingers. It gets confusing because I got to find out where you're from. Right? If you're in China, I'll have one durian. If you're in the United States, we're number one. If you're in France, I'll have one croissant. So don't number fingers. Name them. Thumb, index, long, ring, and short. That's unambiguous. Always discuss things on the forearm and hand as radial or ulnar, as to side, and dorsal or volar, and by their nearest joint. So, a laceration here is on the radial aspect of the forearm, just proximal to the wrist. But metacarpal fractures, boxer's fractures we see all the time. I love looking at the differences in literature between, for example, the UK and the United States. The UK has a bunch of treatment nihilists, socialized country. All they really care about is how soon are you back to work paying taxes. That's what they want. So with their approach to a boxer's fracture is, ACE-RAP, return to work immediately. You're going to have some pain. Our approach to a boxer's fracture, and you're not going to be a hand model. Our approach to a boxer's fracture is to do all this shit where we put it in a splint, ulnar gutter, we, hematoma blocks and pushing. All that doesn't work. The outcomes are the same if you do nothing and if you do all the stuff that we do. But there you go. So it's always kind of interesting to look at that. For any metacarpal fracture, the bottom yellow box here, really, really important. If there's a rotational component, so when you see a spiral metacarpal fracture, there's almost always some rotational component to it. That rotational component is going to destroy the grasping function of the hand because when you go to close your hand, it's going to roll under, And so that's why rotational displacement is not acceptable. A little flexion displacement, what does that give you if you have some flexion, if your metacarpal heals a little flex like a boxer's fracture? What do you get from that? You get extensor lag, which means you say to your finger, go all the way up, and it goes up to here because the fracture's in a flex position. So what happens when that happens? You remotor program very quickly to pull harder so it'll come up all the way. So 5, even 10 degrees of extensor lag due to a flexed carpal fracture, that's no big deal because you'll relearn. They always tell you, say you had someone with spaghetti wrists, you were doing some extensor tendons, and you got in there and you did your whole thing. As a resident, you love to do those extensor tendons. You'll never do them again, but you do one, and then you tell the person, give me the finger, and they go like this. You're like, oops. I attached the wrong one to the wrong one. No big deal. They'll remotor program that. Honestly, that's what will happen. They'll remotor program. The same with extensor lag. So there's a boxer's at about 40 degrees. You could expect, if you just ace wrap that and return to work, they'd have about 5, maybe 10 degrees of extensor lag, which they would figure out and pull harder and get their fingers to open up. How much angulation are you allowed on metacarpals? And so if I put my hand up here, it's 10 for the index, 20 for the long, 30 for the ring, 40 for the short. 10, 20, 30, 40. Some countries use a little more conservative. Some say 10, 10, 20, 30. But I think the 10, 20, 30, 40 is really easy to remember, and that's pretty standard exam answer. And you can put ulnar gutter splints. If you really need to hold them out to length or straight, they need circumferential cast with an outrigger. And we don't do that often in the emergency room. At LA County, we did it all the time because we had the PAs with the orthopedic skill to do it. And so we would put them in short arm casts with outriggers to hold them out. And that works fine, but if you think an ulnar gutter splint or anything short of that is going to hold those things where you put them, it's just not happening. And the reason is because all the flexors in the hand and the forearm are way stronger than the extensors, right? Your hand is an alligator. All the extensors and stuff are just about getting the jaw open. All the flexors are designed to close it, and the closing strengths are high. All you have to do is go watch a Cirque du Soleil show where you'll see that, we used to move around in our world by swinging from branch to branch. Your flexors and your forearms are designed to be able to carry your weight. That's what they're designed for. And if you go to, like I say, Cirque du Soleil, you'll see a whole bunch of people who can still do it. Most of us, not so much anymore. Certainly me, if I was to put my whole weight on my forearm flexors hanging on a perfect sized branch, my forearms would be like, asshole, lose the belly. If you want to hang here, you gotta trim down. You gotta trim down because I'm not holding that weight up. So the flexors will pull fractures off into a more flexed position, generally speaking. Metacarpal fractures of the head, always be careful if they're open. They are often open. That's how they happen. If it's a clenched fist injury, worry about, the fight bite, those types of things. They should be referred to orthopedics. They do badly. They get a lot of post-traumatic infections and post-traumatic arthritis. Then we got the two of the base of the thumb, the Bennett's and the Rolandos. The Bennett's is an axial load where you get a sort of an angled fracture. Theoretically, you could reduce this. The problem is when you do reduce it, and I've had one of these, when you do reduce it, it tends to fall apart because it's hard to make a splint. Even if you do a thumb spica cast, right, the hand is so swollen at the time you place it that after a couple of days of elevating it and icing it, the swelling goes down and then the thing falls apart and they decide to ORIF it. And the Rolandos is the comminuted intra-articular fracture at the base of the thumb. Those always need ORIF. And the Rolando has a worse prognosis. Again, remember for the eponymous fractures, they'll show you or explain what the images are. It's a little helpful. That's Orlando's on the right. That's the bad one. The Bennett's on the left. That one you might be able to fix. Always questions about flexor tenosynovitis. It's one of the most common hand emergencies is when there's a puncture wound somewhere along the flexors, the infection gets in there, and Canavel in 1947, who was an orthopod, remember this was before they had advanced imaging, he wanted to develop an easy way to separate finger cellulitis from flexor tenosynovitis. So if you were trying to identify a way to separate those two entities, do you think redness would do it? No, they're both red. So don't fall for it on the exam. Understand what Canavel was doing. Redness is present in both finger cellulitis and flexor tenosynovitis, so redness is not going to be one of Canavel's signs. What Canavel's sign, as I said, is if they have fusiform swelling. You don't get fusiform swelling with a finger cellulitis because it's the skin. It'll cover the whole thing. But the flexor tendon ends between the PIP and the DIP, so the finger should be tapered, fusiform. Pain on palpation of the proximal sheath away from the redness. That'll help identify an FTS. Pain on extension, if you extend it, that's going to hurt, and held in flexion. So those are the things, and the treatment is obviously to go to the OR for these, and so that was what Canavel's rules were about, telling the difference between something that needs to go to the OR and something that you would treat with soaks and antibiotics. Now here you see a good example of fusiform digit. I wish they weren't showing me the dorsal aspect, but there also seems like a little bit of swelling up above the MCP joint, but I'd really like to see the other side to know that that's an FTS. Fingertip injuries, zone 1, 2, 3, and then the international classification. I don't know where they gathered. They probably gathered somewhere in Geneva to come up with the 5-zone one. I don't need 5 zones. I do the 1, 2, 3 as shown there. Finger dislocations, these are usually fun, except for when they're very frustrating. So most times you can just easily pop them back in, and you may or may not use a digital block. Do shared decision making. You want 2 shots, or do you want me to just pull on it? Most people kind of look at me like, well, I mean, to numb it, I got to give you 2 shots, and they're like, just pull on it then. And so let's kind of go over those. So the DIP is pretty uncommon, but when they do occur, usually there's nothing interposed. DIP dislocation can usually pull and splint. PIP dislocation is really the most common by far, and they come out in 2 directions as shown here. The top one, where the distal phalanx, where the middle phalanx rather, is on the volar side of the joint, that can buttonhole through the volar plate. So that top image, you'll see one of those, and you're like, I'll just pull on it. And you're pulling, and the veins like coming up on the top of your head, and you're getting like frustrated, and it won't go. So then you give them a digital block, and you pull on some more, and it won't go, and it won't go. And you're thinking to yourself, am I really going to call an orthopod and tell them I can't relocate a finger? I mean, it's one thing to call for a bad hip or a big shoulder. I'm going to call the orthopod and say I can't get a finger in? No, so don't do that. Call the orthopod, say it's buttonholed through the volar plate, or the volar plate is interposed, it needs open reduction. They're like, oh, damn. Then they'll come in. The top one, the lower image where it comes out dorsally, there's nothing in the way of those. Those will almost always go in because the volar plate is usually intact with the lower image. It's the upper image where the volar plate can be involved. You know, when you try and put all your weight and you're swinging from a tree branch, right, you need a really thick piece of leather here. We got that, the palmar aponeurosis. You need a really thick piece of leather here across the heads of the metacarpals. We got that. That's called the transverse ligament of the hand. You need a really thick piece across the bottom of these joints so that the phalanxes don't hurt when you grab the branch. We got that. That's called the volar plate. That's what all those things are. And when you see a gymnast, you know, one of those women who's on the uneven bars, put that big hook on their hand, that big hook that they use to grab onto the bars, all they're doing is increasing the strength of their volar plate, their transverse ligament, and their palmar aponeurosis. That's what they're doing when they have those, because of the forces that are going to be exerted on the palmar side. All right, finger packs, some subungual hematomas. I like those. You should trephinate them. Different people have, how big is it to trephinate? If they can feel their pulse, if you say, how's that feel? They go, I can feel boom, boom, boom. If they can feel their pulse, I drain it, no matter how big it is, even little ones. I like to do the spinning 18-gauge needle. I find that works out well. You can do the red hot nail. How many of you use the red hot nail trephinator? Where do you find it? The nurses are using it to smoke outside. That's where it is. They use it to light cigarettes. If you're going to use the red hot nail trephinator, I now know of 2 people that have had this happen to them, where they had a patient, I have got bad pain tolerance, so they're spraying the ethylene chloride. Spray, 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 spray. The chuck is all wet with ethylene chloride. Spray, spray, spray. Red hot nail trephinator. Boom! The whole shit blows up. So I was taking care of a lady who got bit on the nose by a dog. It was one of those LA dogs in a purse. Oh, how you do there? I'm still a dog. But anyway, so I was taking care of her, and she asked if I would be her expert witness. I was like, oh, I don't like where this is going. Would I be your expert witness? I was trying to stay casual with her, I'm cleaning up the nose and doing something. She says, yeah, I had this terrible thing happen to me. I said, well, what happened? She said, well, I was in an emergency room, and I had this fingernail problem, and they sprayed, and then it blew up, and I now have a brachial plexopathy and regional pain syndrome from lunging away from the explosion. Would you be my expert witness? You're so nice, doctor. I was like, oh, God, what do I say? And I said, we're really worried about infection in those, and I think the standard of care is to blow them up. I'm sorry this happened to you, but I don't think I could be your expert witness. Really concerned about infection. Yeah, they took all the ethylene chloride out of the. Diane was talking about how you're taking your boards. Just put a fan and blow it on them. You can't find one. Jaco took them all away. Right? Go ahead, use the ethylene chloride. You can't find them. They took that shit away because it explodes. The nail trephinator, interestingly, they haven't taken those away, even though they're mostly used to light cigarettes in smoke-free institutions. They'll get there. I was on the jail service. You know how everyone knows they're coming, right? So they put me on the jail service. Maybe they thought, how much trouble can you get in over there? So I was over there, and of course, Jaco came to see the emergency room, but they're not Jaco anymore, are they? What do they call themselves? The JC. So they came through. We're the JC. So they come into the jail, and because at the jail we got a Sally port, they take their IDs away. So they come in and start looking around the rooms. They go, excuse me? I didn't know who they were. What are you doing? They go, and the nurse who's with them, the administrator who's afraid that someone's going to get in their way, oh, they're with the Joint Commission. I go, I don't give a shit who they're with. If they don't have ID, they can't come looking around this area and looking into patient rooms. This is a vulnerable patient population specifically, and if they don't have any ID, she says they took their ID away. Fine, then get out of here. You can't come in here without an ID looking around patients' rooms. I don't know who they are. We're the JC. So then I said this really got them. I said, and I find that offensive. They looked at me like, what? I go, I'm an Irish Catholic kid from Boston. Trust me, I have a JC. And that JC is pretty sure it's the JC. I find your name religiously offensive. At that point, I'm not religious at all, by the way, but at that point, they just left. And I was snickering. Remember that cartoon character that used to do that was me after they left. I could barely contain my joy with the religious offensiveness. So next time someone comes from the JC, tell them you went to a Jesuit college and you're offended. We're with the JC. So annoying. Please ask me about something irrelevant, that you could cite our hospital for, so that we could spend a huge amount of time and 5 committees can have a conniption doing nothing. So helpful, the JC. All right, FDP and FDS, you got to know how to examine them, right? You got to hold the whole finger, make the little end of it go, right? That's FDP. And then I got to check rein the other 2 fingers like this, right? That's FDS. And so you got to check for FDP and FDS. Extensors, you got to make them extend. Now, let's talk about this. Why can you do this and not so much this? That kind of hurts. I can see you. Girls are more flexible. They have less crossing pieces. She's like, I can do this. What are you talking about? This hurts a little bit on a lot of people, but this doesn't. That's because there's 2 extensors to these fingers in most people. So when someone can do this, it means an extensor is intact, not that both extensors are intact. So if that's all you look for, you'll miss extensor, digiti minimi, and all that stuff, so you got to look for those. All right, FDP and FDS. This is the safe position that's talked about for splinting. You can put them in the position of function, like, holding a beer can kind of thing. That's fine for short-term splinting. But if you're going to splint someone for longer than that, 4 or 5 days or longer, they should be in this position, which is called the intrinsic plus position in orthopedic literature. But sort of in common parlance, if I put my hand in that position, it looks like a garden hoe. See that position? So it's called the blade of the hoe position. You got to make sure you make the garden reference because we're in Vegas. It's the blade of the hoe position. And the reason you would put it in the blade of the hoe position, which has extension, see the extension, 20 degrees at the wrist? If I just leave my wrist limp like this and make a power grip, watch what happens to my wrist when I make a power grip. It comes into extension. So the power grip of your hand brings your wrist into slight extension. So since the wrist is a joint that freezes when it's splinted for any length of time, you do not want it to freeze in a position where you lose the power grip. So you splint it in slight extension, 20 degrees, as shown here. The MCPs you put at 90, and the PIPs you put at 0. Now, I had a pretty bad injury to this arm when I went off a motorcycle. No finger involvement. Had surgery, had a bunch of stuff. And then after it all came off and I had to do some hand rehab, what hurt? Oh, the MCP and the PIPs. I can't tell you. This is really important. If you're splinted for a longer period of time, you need to be in these positions. Man, that little finger rehab, oh, she hurt me. Trying to get the MCPs and the PIPs to work is really what hurts the most after that. Here's the other position that you might go in, sort of the hold the beer can. That's fine for short-term splinting. You got a burn or something minor that you're splinting for a few days, that's fine. Wrist fractures, collies, most common fracture in adults greater than 50, dorsal radius at the metaphysis, the dinner fork deformity. What nerve might be out? Well, the median nerve gets in trouble even when there's no injury, right? We call that carpal tunnel syndrome. So the median nerve is already in a tight position. So anything that happens at the wrist, if you were going to guess which nerve it affected, it would be the median nerve. And when there's exceptions to that rule, we'll talk about them. But in general, anything at the wrist, you should think median nerve. So there's a Colles fracture. This is a person who was thinking of having a Salter-Harris fracture but said, nah, I'm going to skip the Salter-Harris. I'm going to go for the straight Colles. And there's the dinner fork deformity dorsally. Bartons and Smiths are sort of related. Again, you won't be killed on the eponymous stuff. The Bartons is involving, is the fracture and dislocation where you involve the radial styloid version of it. And they can come either dorsal or volar, Bartons can. And here you see, one of each on the picture. And then the Smiths, which is really the reverse Colles with volar displacement. That's usually when someone falls with something super important in their hand that they can't drop, like a beer can, that's usually what it is. Or they go over the handlebars on a motorcycle or something like that. Then you have this x-ray shown with the 2 short fat arrows. Those are little. This is a person who fell forward on both hands. Pretty common story, right? Mechanical fall, both hands, and both hands hurt. The other views of the x-rays, the other views of these hands are negative, and so all you got is these 2 red arrows pointing to a dorsal chip fracture, and they ask you, what is it? And you just have to know that by far, 90% of the time, the most common dorsal chip fracture of the wrist with a fouche, so I gave you all that, fall on outstretched hand, dorsal chip fracture, that's a triquetral fracture. You just have to know that. Because you can't tell which bone it is, even if you knew all the bones in the wrist well. And because on the other view, you can't see the fracture. So you just have to know it's the triquetral fracture. All right, there's the Smiths, the reverse Colles. All right, Guillen's canal. The ulnar nerve comes down the ulnar side, gets after the wrist. It's, by the way, right here at this level of the wrist, it's right by flexor carpi ulnaris. So I see people who tell me flexor carpi ulnaris is out, but everything's intact. If FCU is out, the ulnar nerve is out almost every time. And then it comes through here and it has to go through a little chicane, a little S-curve. And that S-curve is Guillen's canal. and there's a ligament there between the pisiform and the hamate called the pisohamate. That makes the roof of the canal, and the two bones make the bottom part. And if you do stuff that brings a lot of force into the thenar eminence of your hand, I remember one summer I was chainsawing, I spent the whole summer chainsawing hardwood into 4-foot lengths for cord stacking. And the chainsaw, eventually I started having these ulnar nerve symptoms that it's called handlebar neuropathy. It'll happen with jackhammers. It'll happen if you're using a sledgehammer a lot. It's one of the reasons why sledgehammers, you should choose the right sledgehammer for the strength of your forearm. That's why they come 8, 12, and 16. And almost no one uses a 16 because their forearms aren't strong enough. The vibration will be transmitted in, and you'll get this kind of problem. All right. Guillen's canal with the ulnar nerve neuropathy. One of the things about the ulnar nerve is it's vulnerable. That's why it's vulnerable, has the word ulnar in it. Vulnerable. It's vulnerable at Guillen's canal. It's vulnerable at your elbow for the funny bone where you've all smacked it and went, ow, son of a bitch. It's vulnerable there, and it's vulnerable up at the brachial plexus as well. So you could have ulnar nerve involvement at all 3 levels. It's vulnerable. All right, here we have the gap between the scaphoid and the lunate, the scapholunate dissociation, the most common important ligamentous injury of the wrist. It can be missed. Do they have to be separated by 3 millimeters? No. If you don't discover it and the hand falls apart at the proximal carpal row, which it can do, that's called SLAC, scapholunate advanced collapse syndrome, SLAC wrist. And so this is a pretty important injury. Remember that your wrist has intrinsic ligaments and extrinsic ligaments. The extrinsic ligaments go all the way back into the forearm. They make sort of a big X across the back of your wrist and a big X off the bottom of your wrist. Those are the extrinsic ligaments. The intrinsic ligaments are the bone-to-bone. So if I was to ask, which is this injury, this is the most important intrinsic ligamentous injury of the wrist, not extrinsic. It's an intrinsic ligament between the scaphoid and the lunate. And this should get a thumb spica and referral, and they're at risk for problems with these. And you'll see someone every once in a while come in the emergency room, yeah, I injured my wrist a year ago, and they'll tell you if I pick up a 5-gallon bucket or if I grab something, I get this clicking thing in my wrist. And you're like, I don't know what that is. You might have said that to someone. But because I give these talks and have looked these things over and over again, what that is, that you're finding is the beginnings of scapholunate advanced collapse. That's what that clicking is in their proximal carpal row. They had this injury. It never got fixed. It's over time getting more lax. Perilunate and lunate dislocations, all the problems here. So these continue to be missed because people are unfamiliar with the 4 C's of the wrist and unfamiliar with the x-rays, and so they get missed. And then there's also the issues that they're misnamed. Now, these are significant injuries at the wrist, so which nerve do I worry about? The median nerve, as always. And so let's look at them and get them right. So, who named this? Like, what stoner orthopod called this a perilunate dislocation when it's clearly what it is a capitate dislocation? So let's do the 4 C's of the wrist. See that shallow cup at the end of the radius, the distal radius? That's C1. See the cup where the proximal portion of the lunate sits in the distal radius? That's C2. And in this x-ray, C1 and C2 are talking nicely to each other. That joint is intact. Now the distal pole of the lunate has a little shallow cup. That's C3. And the proximal portion of the capitate, where it's curved, that's C4. And as you can see in this x-ray, C3 is not talking to C4 whatsoever. The problem is C4 is not where it should be. It's a capitate dislocation. And if you told me, Dr. Mallon, you don't have an orthopod or you're going to be stuck without this, I'm pretty sure I could get that back in place with some pain control, some relaxation, and some Chinese finger traps. I'd yank on that bad boy until that capitate came out to length, and I'd snap it back over into that little hollow of the lunate. That's fixable. If I was stuck, I could fix that. Now, let's go to the lunate dislocation. C1 is the distal portion of the radius. It's not quite talking right to C2, right? They're not nested nicely. C2 is tipped, and C3 is not talking to C4. So now we know which of these is worse injury. The lunate's a much worse injury because both C1 and C2 are disrupted and C3 and C4 are disrupted of the 4 C's of the wrist. Both are disrupted. The T-cup is tipped. This one, no matter how hard I pulled on the capitate with the finger traps, I'd be worried that I couldn't get the lunate to tip back in the right position. So this one would be much harder to fix. Okay, so we got the perilunate. I don't know what they were thinking. That's a perilunate injury. That's a capitate dislocation. That's what it should have been called from the beginning, and it wouldn't have confused anyone. And then we have the lunate dislocation, which is what it says it is. Tenderness in the snuff box. You're always supposed to think about a scaphoid fracture. Even if you get 6 views of the wrist, 6 views, plain films of the wrist, you will miss 20% of these. So that's why if they have clinical findings, you should put them in a thumb spica. And so, snuff box tenderness, that's one of the clinical findings. Scaphoid tubercle tenderness, that's another one of the findings. And finally is axial load tenderness. What you do after that point when you suspect it and the x-rays are negative depends on who and where you are and what your resources are. Okay, the options are to MRI it right now, sort it out, and some people would do that if they had the resources to do so. The other options, the other lowest budget option is to come, we're going to put you in a long arm thumb spica splint and re-examine you in a couple weeks and repeat the x-rays. But that would require you to be splinted for 1 to 2 weeks. And then in between there are other various options. But if you're going to do the advanced imaging, know that the CT isn't good enough. You need the MR. The CT misses some in addition. The complication here is AVN, and that's because the radial artery comes down the radial side. Radial artery goes past the scaphoid bone. Then it gives off this branch called the deep branch of the radial artery that goes up and does a button hook, comes back to the bone and perfuses it in a retrograde retrograde way, so that the distal pole of the scaphoid is in the proximal circulatory bed, and the proximal pole of the scaphoid is in the distal circulatory bed. And so a fracture through the waist makes the proximal pole at risk for AVN, and the reason that's such a problem is because it's the largest articular surface area of the wrist. So there's a lot of problems with post-traumatic arthritis and things like this. And this is a great x-ray, by the way. Here you can see the fracture through the mid-third, the waist of the scaphoid. And so you can imagine how that whole proximal portion of the scaphoid might be devascularized. You also have a fracture of the radial styloid and the ulnar styloid here. So this is, remember, whenever you find one positive on an x-ray, there's a tendency to be relieved, oh, I found it, and go about your business. No, you need to become more paranoid. Whenever you find one positive on an x-ray, it doubles the chances that there's another positive. Doubles the chances. So keep looking. High pressure injuries, grease guns, paint guns, hydraulics. These can look very innocuous and turn out to be very bad. And so your willingness to consult the hand surgeon first thing in the morning or immediately should be very high, even when they look like nothing. I was an intern. I was on ortho. Intern year, you're always, in emergency medicine, you're always the foreigner on the service. You're not one of their interns. So interns back then were already treated badly enough, but you're the rotating foreigner. So there I was, a little ER doc on ortho, an intern. Okay, what do you need me to do? Okay, run. Okay, got it. And so then this pressure injection injury to the thumb, right on the thumb, looked innocuous. And they started screaming at me like it was my fault. They're like, look at this bullshit sent up by the, who set this up? Who accepted this patient? And there's like, I'm like, I don't know, I have nothing to do. I'm sorry, I won't make that mistake when I'm a resident. I'll try and be better. I won't try and make these mistakes that make you so bad. They're yelling at me, and I was like, all right. I said, what should we do? I said, do you want me to get the discharge paper? No, we'll watch it overnight anyway. And in the morning, it didn't look so good. And the next afternoon, and I was working nights on this ortho. Next afternoon, it really started to not look so good. So then they took it to the OR. And that case, 14 hours. So when I was leaving my shift at 7, I got to scrub in during a portion of the night. They were up in the axilla, pulling latex paint out of his armpit. They'd already dissected the whole arm and the whole forearm, and they'd opened up the carpal tunnel, and it was all a mess. And I couldn't help myself as I left the OR. Oh, those ear docs. Guess they got it right. As I slinked out of the OR. So don't underestimate them. They really can look like nothing. There's a great picture on the internet of a high pressure hot molten metal injector that somehow got somebody's palm, and the hot molten metal fills up the palmar spaces, goes through the carpal tunnel it's got to hurt no matter what, even if it's just latex paint. It's got to hurt like hell. But the hot molten metal, that's got to hurt. And I'm going to stop. It is 8:31. I am 55 seconds over. I see Peter Sokoloff over there waiting in the wings. Peter. And we will pick up here.